Good evening, everyone, and welcome to the webinar on the theme Let's Talk Managing ALK Positive NSCLC in 2026. It gives me great pleasure to invite our chairperson, Dr. Purvish, President, Asian Geriatric Oncology Society, Mumbai, to give the welcome and context setting. Over to you, sir.
Thank you very much, Himanshi and Kavina. Welcome, Ashish, Kaushal, and your team of panelists. I think lung cancer has progressed a long way. When I was a student, the median life expectancy of lung cancer in advanced stages was only 8 to 10 months. And today, now, when we look at the subset of ALK positive non-small cell lung cancer, we are talking about a significant 8-year survival in patients who have this particular molecular change. Now, you might say, what is the need of a ALK mutation lung cancer webinar? Because it is well known. So the reason why this webinar is important are for a few factors. One is that we have more than one ways of treating this patient. So there are first line, second line, and third level of drugs available. Second is that the biology of the disease is different in the younger age as compared to the older population. It is more aggressive in the younger population. Whereas in the older population, though the biology is less aggressive, the host could be compromised because of comorbidity. So we have to balance it. The third thing is that the ALK rearrangement is not a single mutation. There are 3 variations. And the variation 1 is the most common one, which is favorable. Variation 2 is also favorable, but it's very rare. And then we have variation 3, where in spite of being ALK mutation, it responds only to the 3rd generation molecule, and therefore we have to be extremely careful. And the last factor that is important is when there is a brain metastasis or involvement of the brain, which drug to choose is exceedingly important. So for the introduction, I will stop here. I'm sure that Ashish will discuss all of these in great detail. And Ashish is a very senior medical oncologist. He has a vast amount of experience, and he has, got a background from the academic as well as corporate hospital. He is now the senior consultant at KD Hospital in Ahmedabad. So, Ashish, over to you.
Thank you, sir, for a nice introduction. Can I share my screen?
Yes.
I hope my screens are visible, right?
Yes, sir.
Yes, we can see it.
So I think, as sir has rightly mentioned, we are discussing a very interesting topic, that is the ALK positive non-small cell lung cancer. As I'm also a witness, like the lung cancer in metastatic disease. Initially, we cannot expect the life expectancy more than a year, maybe a decade ago. But now with this molecular-based precise medicine, we can extend the survival in years. Some patient more than 5 years, 8 years, as sir has rightly mentions. And especially the ALK positive patient, we have various options. So today I'm having a 2 session. First, I'm going to speak about one talk, and the second would be the moderation. So the talk would be on the bridging the gap in the ALK positive non-small cell lung cancer with brigatinib. And as we know, we have a significant burden in India, even on the ALK positive, though the incidence in India of ALK positive non-small cell lung cancer is somewhere around 3 to 8%. But ALK is a very interesting biomarkers, and where we have a very, very effective target agents. So this is basically a receptor tyrosine kinase, which is identified as a driver oncogene in some patient with the non-small cell lung cancer. And the character of this particular ALK regimen is different from other type of non-small cell lung cancer. The majority of the patient having no history of smoking or very light smoking. The patient age group was very much different. It is a more younger population, and the median is somewhere around 52 years compared to the 71 years for the rest of the non-small cell lung cancer patient. Majority of the patients are diagnosed in advanced stage. I would say 90% patient having their metastatic disease, and compared to any other subtype of non-small cell lung cancer patient, this ALK positive patient having a more frequent brain metastasis. So typically they have a different clinical presentation, different age group, advanced stage, and even this is not very much associated with the addictions, especially with the smoking. If we talk about the treatment options about ALK positive non-small cell lung cancer patient, so we have a various options started from the chemotherapy with the ALK targeted agent, but the first, this EML4 ALK identified as a driver oncogene in non-small cell lung cancer is long back in 2007, but we have a first agent which is approved for this particular cohort is in 2001, crizotinib as a isolated approval with any line of therapy in 2011, followed by the full approval in 2013. And we have alectinib post-crizotinib approval in 2015, full approval in 2017. And brigatinib and lorlatinib has got a post-crizotinib approval in 2017-18. And finally, the full approval in 2020 in the first line setting of brigatinib. Lorlatinib is in 2021. And last 2024, we have a alectinib approval in the adjuvant setting and another drug is called ensartinib, which is not available currently in India in 2024. So this is the development in the ALK positive non-small cell lung cancer. We have a various agents starting from crizotinib with alectinib, lorlatinib, and brigatinib. All other second, third generation agents we have now. So what I'm going to talk about brigatinib, which is a ALK tyrosine kinase inhibitor, and this is now available with us, the introduction and the clinical overview. So it is basically a TKI with a selective preclinical activity against the ALK and the ROS1, and it inhibits the in vitro proliferation of the cell lines expressing the EML4 ALK and NPN ALK fusion protein that demonstrate the dose-dependent inhibitions. And this inhibition is an in vitro viability of the cell line expressing the EML4 ALK and 17 mutant form that associated with the clinical resistance to ALK inhibitors. And it also shows the anti-tumor activity against the 4 mutant form of the EML4, including G1202R, and one of the common mutations is the L1196M, acquired resistant mutation. And also they showed a reduced tumor burden and prolonged survival in the mice implanted intracranially with the ALK-driven tumor cell lines. So it is a very, very effective TKI, especially for ALK rearrangement patients. Currently, it has been approved in India with the two settings. One is a monotherapy in patient of adult patient with ALK positive advanced non-small cell lung cancer, which is a treatment-naive patients, or those patients who is initially received the crizotinib. So as indicated in the monotherapy for adult patient of ALK positive advanced non-small cell lung cancer prior treatment with the crizotinib. The standard dose to initiate with the 90 milligram initially orally for 7 days, followed by a dose escalation of 180 milligram once daily, and is to be given with or without food. So it has been approved in all international guidelines. So we have NCCN guideline of ALK positive non-small cell lung cancer patient, those patients with the ALK rearrangement. If this ALK rearrangement is discovered prior to initiating with the systemic therapy, we have been approved brigatinib along with the other ALK inhibitor like alectinib, ensartinib, and lorlatinib. And if the ALK rearrangement is discovered during the first line systemic therapy, it can be given as a first line. We can interrupt the current therapy and start with the ALK inhibitors. So brigatinib is mentioned as one of the preferred agents. And if there is a progression of ALK inhibitor, the biomarker testing should be done to determine the mutation status, and that will be helpful in the deciding the future line of therapy. Similarly, we have ESMO guidelines, which is also recommend the brigatinib in the front line as well as the subsequent line. So those patients who has received the first line ALK inhibitors like brigatinib, and if the patient having any kind of progression, then based on the progression, we need to decide the subsequent line. Those patients where there is a oligoprogression, then we can offer a local regional therapy and continue with the same targeted agent which was giving the response. But if there is a systemic progression, it is recommended to get a biopsy done to look for the histopathology, and if the patient having still positive, we can offer the subsequent line. Those patients who receive the initially crizotinib, we have an option of alectinib, brigatinib, and ensartinib. But if the patient hasn't received other than crizotinib, then we have an option of lorlatinib. And even after that, there is a further progression. So the patient can be given a chemotherapy or BCB combination and lorlatinib if the patient not received lorlatinib earlier line. So this is the nutshell of the ESMO guidelines. As far as the mutation is concerned, the ALK resistant mutations is very common after the first line of therapy. Most of this mutation is the acquired mutations. And if you can see, the brigatinib shows very, very effective, almost all kind of the ALK resistant mutation, especially for L1196M and G1202R, which is a quite resistant mutation, which is only effective for the brigatinib and the lorlatinib. As for the efficacy of brigatinib in the first line, we have various data. The most important is the ELTA1L, and other studies are Bright Star and Explore L, where the brigatinib is being tested. So ELTA1L is basically a phase 3 randomized open-label multi-center international study where the brigatinib is given in the first-line ALK-positive non-small cell lung cancer. The classical inclusion criteria for this study: the adult patients of 18 years more, locally advanced or metastatic non-small cell lung cancer, where the no local therapy has been recommended. The ALK testing is done by local testing. The patient of either a patient of ALK TKI patient, or if the patient receive any systemic therapy, one therapy is allowed for advanced non-small cell lung cancer patient. Randomization is done 1:1. So the arm A patient received the brigatinib, and arm B received the patient's crizotinib, 180 and 250 milligram. And the study is done based on the presence of the brain metastasis or the prior chemotherapy. So patient has been given this therapy, continue till there is a disease progression, which is assessed by a blind independent review committee, or if the patient having any safety issues, particularly in tolerable toxicity or other reason of discontinuation. One of the interesting thing in this study, those patients who have increased the crossover is allowed with the brigatinib if there is any progression assessed by the review committee. The assessment has been done, including the brain MRI for all patients every 8 weeks through cycle 14. And the primary endpoint for this study is the PFS by RECIST criteria 1.1 by review committee assessment. Secondary endpoint is the confirmed overall response rate, integrin overall response rate, integrin PFS, overall survival, disease control rate, duration of response, health-related quality of life issues, and the safety parameters. And there is a selective exploratory points that includes the PFS and the confirmed overall response rate by the review committee in patient crossing over the crizotinib, PFS and AUC relationship. In this study, the statistical consideration has been based on the 270 patients, 198 events, 1 day to 35 in each arm to detect a 6-month improvement in the PFS, assuming a median PFS of at least for 10 months in crizotinib arm. Through interim analysis and one final analysis will be planned in the primary endpoint of blind independent review committee assessed PFS. And this is the patient profile, which is a reflection of the real one patients. The median age for brigatinib arm is 58, while in crizotinib it is 60. The female 50 versus 59. Asian patient is somewhere around 40%. And majority of the patients are ECOG performance either 0 and when it is 96% in the both arm. Quarter of the patients received the prior chemotherapy, that is 26-27%, and brigatinib in crizotinib arm. And the patient having the adenocarcinoma stage 4 or almost light or never smoker is more than 90-95% patients. So majority of the patient having the stage 4 adenocarcinoma patients. If you see the outcome of this study, the brigatinib shows a very significant efficacy as for this ELTA1L study. So the median PFS, if we compare with the crizotinib, is 30.8 versus 9.2 months. So more than 3 times the PFS compared to the crizotinib. So the HR is very impressive, 0.43, and then there's 57% reduction in the risk of progression. And this is the PFS investigator assessment reviews. So very, very effective data as for the PFS concern. If we talk about the integrin efficacy, the brigatinib shows a very significant and long-lasting integrin response compared to the crizotinib. So the median integrin PFS in patient with any brain metastasis at the baseline is 24 versus 5.5 months, and the HR is 0.29. So very effective data, and the complete response in patient with any brain metastasis at the baseline with Elunbrig, it is 45% CR versus 2%. So very, very effective data. The median duration of the confirmed integral response is 27.1 months with brigatinib compared with the 9.2 months with the crizotinib. So very, very effective, and the HR is quite impressive, 0.294 integral PFS. The median PFS of 4 years in patients with or without brain metastasis. So if you compare with the intended population, where the patient having either brain or without brain metastasis, the median PFS is 44.1 versus 21.2 months. So 56% reduction in the risk of progression for intracranially, that is HR is 0.44. In this study, the quality of issue has been assessed, and the brigatinib delayed the worsening of global health status and quality of life. So the median time to worsening in the health-related issues is 26.7 months versus 8.3 months. The HR is 0.7. This time to worsening was assessed by physical scales, emotional, cognitive, and social functional scales, and improvement of the disease symptom. So very, very significant data. And study design to select the phase 1, to select the first line LTKI. So we have a very the standard 3 landmark study, Delta 1, ALX, and Crown. So ALX for the alectinib, which is compare alectinib versus crizotinib, while in Crown it is lorlatinib versus crizotinib. So in various studies there's a different parameters, but in brigatinib they have taken a more real world situation. Many times what happened, we give the systemic therapy because the patient's molecular profile is abated. So in this particular study, the one chemotherapy regime is allowed in Delta-1L, which is not allowed in ALX and Crown study. Another important difference is the crossovers, which is allowed. So those patients have crizotinib, they've been given an option of brigatinib progression. And the primary endpoint was PFS was assessed by the blinded interview committee in the Delta-1 study, while in ALK it is investigator associate. And this ALK testing was performed locally, while in ALK study it is centrally, and Crown study it is both local and centrally it was allowed. So different trial has in different study with respect. Another study other than the Delta-1 is basically the Bright Star study, where the brigatinib is in combination with the locoregional therapy and the treatment-naive patients. And this Bright Star study is basically a phase 1 trial of the locoregional therapy in combination with brigatinib in treatment-naive advanced non-small cell lung cancer positive patients. The key inclusion criteria for this Bright Star is basically the adult patient with documented ALK rearrangement. This patient is the treatment-naive, 1 or more site for residual lesion. The ECOG performance is 2 or less. And the patient is giving brigatinib 180 milligram daily on day 1 to day 28 for up to 2 courses, and followed by the locoregional therapy for 3 weeks. If there is a less than 3 sites for the disease, then locoregional therapy to all the sites. If there is more than 3 sites, then the local therapy is for the physician discretion. And after the local therapy, the brigatinib is continued till progression of the disease or as a toxicity. The primary endpoint was the safety and the tolerability, and the secondary endpoint was the PFS, OS, treatment time to progression, and on non-locoregional therapy lesions. So the objective of this particular study to assess the safety and efficacy of brigatinib in combination with locoregional therapy in treatment-naive advanced ALK-positive non-small cell lung cancer patients. And this is the patient characteristic, and the number of the patients included study 4 patients. And we can see the response at the 8 week after the giving the brigatinib. In this particular slide, you can see the patient having the partial response is around 79%, and 21 patient having the stable disease. So the disease control rate is somewhere around 100% with this particular study. And majority of the patient of adenocarcinoma patient and the patient having V3 variant is somewhere around 50% patient. In this particular study, the locoregional therapy was given radiation in 79% patients, surgery in 9%, and 6% combined combination surgery and radiation. And it is very well tolerated, and grade 3 and grade 4 toxicity is somewhere around 3% of the patients. And out of radiation, the IMRT and VMAT is given in almost 20 patients. And the brigatinib held during the radiation 19 patients. The median PFS for this Bright Star study is very impressive, 66 months in the first line, and with the 61% 3-year PFS, very impressive data. Another study is for real-world evidence of ALK inhibitor for brigatinib is the Explore ALK study, which is a prospective non-interventional study of first-line ALK TKI monotherapy. So this study is still ongoing. It's a prospective non-intervention multicenter study in France in patient with the ALK-positive non-small cell lung patient treated in the first line with the brigatinib, alectinib, and lorlatinib, and started from the July 1st, 2020. The inclusion criteria for this study is the adult patient with the histology and cytology confirmed advanced non-small cell lung cancer patient. These are the treatment-naive patient. The patient with the brain metastasis, either treated or untreated, symptom or all are included. And the first line treatment as per the physical description, whether it is the brigatinib, alectinib, lorlatinib. The primary endpoint with the overall survival, the study is still ongoing. And the secondary endpoint is the typing of the study population, treatment sequence, efficacy, and the safety parameters, and the disease progression modality, and the current practice to identify the resistance mechanism. And if you see the baseline characteristic in all the three studies, the patient profile is quite similar. The age group, the sex, performance status, smoking history, all patients is a adenocarcinoma, number of metastatic sites. So all has been almost similar in both the sites. So in Explore ALK, they've been found the data of OS is not mature and still the study going in, but the PFS is still not reported as of now. But you can see in the graph, the brigatinib is showing a significant efficacy, and it compared to alectinib is showing a better PFS, but still the data is not mature. Another side is the overall survival data, and I think still the data is not mature, but it is not reported as a not reached basically. And the brigatinib and alectinib both is showing almost very good OS data. And what we can say, the brigatinib is not inferior to the alectinib in this particular study. So brigatinib also been tested in those patients that are pre-treated with the TKI. So there is the ELTA-2 study. So we are going to present the pooled analysis of ELTA-2, LJ-ELTA. So this is the open label single-arm multi-center intervention study. This is a phase 2 study where the adult patient have advanced ALK positive non-small cell patient, where either progression disease alectinib or sunitinib has been included, and less than 3 systemic therapy has been given, and the patient will be an option of brigatinib 180 milligram daily till the disease progression. And those patients having the progression of the on brigatinib, so they have either option to increase the dose from 180 to 240 milligram, or continue 180 milligram if there is a clinical benefit, or the patient has been given discontinuation if there is a symptomatic worsening and progression both. The primary endpoint for the investigator review confirm response rate. So in this particular study, in intended population, where the patient having either giving a selectin and alectinib, they got around 26% response rate, and post selectin it is little better, it's 29.1% patient. So this is all the information. The treatment related tolerance is good, and the patient having some of the toxicity, but that is manageable with this particular study. Brigatinib, particularly after with alectinib, the pooled analysis has been captured in the ELTA-2 and J-ELTA studies, and they found in intended population, the response rate of brigatinib is 31%. The median PFS is 9.2 months, and the median OS is 25 months. And those patients having the brain metastasis at baseline, the median OS is 28 months. So even with the initial treatment, the sunitinib, the brigatinib is effective and improving the overall survival in this particular patient. Coming to the safety profile for brigatinib and the doses administration guidelines. So it is a manageable safety profile in the ELTA-1 study. So 42% patient is continue on break for more than 2 years at the median follow-up of 40.4 months. The discontinuation rate due to the adverse events are comparable between the treatment arm. 13% patient with the brigatinib versus 9% with the crizotinib. One of the common toxicity grade 3-4 is the hypertension, which is reported in 14% patient, pneumonia in 5%, anemia 3%. But compared to the other toxicity like metabolic toxicity and psychiatric problems, which is much lesser compared to the other TKIs. Hypertension is manageable, which is 2% patients require a dose reduction due to hypertension, but there is no discontinuation, no weight gain, and no minimal psychotic impact, no major neurocognitive adverse event except for insomnia in 5% more patients. 3% of the patients of brigatinib have an early onset pulmonary events within the 14 days of initiation of therapy. So the standard recommendation is to give 90 milligram of brigatinib 7 days, then escalation based on the tolerance. So all 4 patients of ELTA-1 shows early onset event, even discontinued brigatinib after the event as per the protocol. And those 65 patients who have any crossover crizotinib to brigatinib, out of that 2% patient have an early onset pulmonary event. So the safety is manageable. Compared to the other third generation TKI, the brigatinib having a low cardiovascular risk compared to the lorlatinib. So compared to brigatinib, the lorlatinib has 3 times more increased risk of cardiovascular issues, which is one of the significant factor, particularly in the elderly population. So we have to be very careful, particularly prescribing this patient underlying cardiac issues. So the standard recommended dose of Elbrick is 90 milligram for once daily for first 7 days. And there is no issues with the tolerance. They increase the dose up to 180 milligram orally once daily. The treatment has to be continued till the disease progression or acceptable toxicity. If the drug is withheld for any reason for 14 days or longer, or other than adverse reaction, we have to resume the treatment again at 90 milligram for 7 days, and then increase to 180 milligram if there is a no tolerance issue. The tablet is to be given as a swallowing as a whole. Do not crush or chew the tablet. The patient should avoid the grapefruit juices while taking this brigatinib. And if the dose of brigatinib is missed or vomiting occurs after taking, do not administer additional doses. The next dose should be taken at the scheduled time. One of the important thing is the once daily dosing. So the once daily dosing is significant, reduce the pill burden. It is 365 tablets in a year compared to the other. It can be up to 730 tablets for other drugs and up to 920 tablet for the high pill burden for other TKIs, especially in positive non-small cell lung cancer patients. So putting all together, those patients which is the most significantly beneficial for brigatinib, the patient having the either history of dyslipidemia or any cardiac problem, particularly with a myocardial infarction, heart failure, or arrhythmias, because they have the low risk of lipid abnormality and low risk of cardiac event compared to the lorlatinib. The patient having a high BMI, diabetic and metabolic abnormalities, so no weight gain, no metabolic side effect with the brigatinib. So these are the patient having the more suitable. And the patient living alone without social support, history of depression, dementia, anxiety, because the neurocognitive side effects are much lower compared to lorlatinib. So this is very important, and particularly with the no drug interactions with the antidepressants. So those patients having any antidepressant therapy, I think lorlatinib is the issues, but brigatinib can be given safely in this patient. And the last is the elderly patient on multiple concomitant medications. So once daily dosing is more convenient to the patients, and there is no food restriction. So it can be given with or without food. So there is one case of 44-year female with ALK positive non-small lung cancer patient, diagnosed in September 2016. And this patient was having non-small cell lung cancer patient, stage 4 patient. The patient having the lung lesions with the brain metastasis. And the molecular profile reveals ALK positive non-small cell lung cancer patient having history of cough with good performance and no major comorbid. This patient was non-smoker. And on the right side, you can see the patient's profile. The CT showing the right lung lesion with the brain metastasis and MRI. Patient was initiated with the first-line therapy with the brigatinib based on the ALK study. And initially, the patient given 90 milligram of brigatinib for 7 days. Patient tolerated that drug and then escalated to 180 milligram. But in a short period of time, patient has to reduce to 120 milligram due to the adverse event. But the patient was responded both with the lung and the brain lesions. And in 2019, after 3 years of brigatinib, the patient having the oligoprogression in terms of the brain lesions. So patient was given a gamma knife therapy. The similar gamma knife therapy was given in December 2019, March 2021, and June 2021. So 4 times gamma knife has been given. Patient responded with this therapy till 57 months. And then patient having the progression, and the patient was terminated for brigatinib. And after the progression of the brigatinib, the patient was given the lorlatinib in the second line of therapy. And the lorlatinib started with 100 milligram doses, but because of the adverse event reduced to 75 milligram. With the lorlatinib, patient responded. There's stable disease in the lung, CR in the brain, because lorlatinib is a very good brain penetration. But at the same time, patient experienced the toxicity of lorlatinib, delirium grade 2. And the patient was continued this drug for the 33 months. And with this switchover therapy, the 57 months of the brigatinib and 33 months of the lorlatinib, and patient has survived for more than 7.5 years with the LTKI. So in metastatic non-small cell lung cancer, the patient has been diagnosed with the brain metastasis beginning, the patient is surviving more than 7.5 years. So this is the something which is interesting. We are getting in advanced non-small cell lung cancer. If the patient has mutation with the switch therapy, you can get very impressive outcome. So summarize of this presentation, a balanced ALK TKI. So brigatinib shows very powerful systemic efficacy. The median PFS 24 months with the brigatinib versus 11 months with the HR is 0.49 significant. And the median PFS 13.8 versus 9.2. And with the Kazum disease investigator assessment final analysis, the HR is 0.44. And the superior intracranial efficacy, the median intracranial PFS 24 months versus 5.6 months with the crizotinib. The HR is 0.25, very significant. And it reduced the risk of progression and thereby 75% compared to the crizotinib. As for the safety data is concerned, majority of the patient tolerated well. The adverse reaction other than disease progression with the pneumonia in 4.4%, pneumonitis 3.7%, Parikh 2.9%, dyspnea 2.2%, and pulmonary embolus 2.2%, and asthenia 2.2%. So it is a manageable safety profile. And one of the important thing is fit to all patients, which is one tablet once daily with or without food. So very, very effective data, significant efficacy, and also it covers all the resistant mutations and very convenient, friendly, patient-friendly dosing. With this, I thanks for inviting me, and I think we need to hand over to the sir for the subsequent chapter. Thank you, sir.
Thank you, Ashish. That was a wonderful exposition. You really covered the most important points in the limited time that is available to you. And I'm sure that you will cover the remaining parts in the panel discussion. So I don't want to stand in between you and the further discussion. Please go ahead with your moderation. And we have some 4 wonderful panelists, all from the state of Gujarat. They are all dear friends, Kaushal Patel, Akash Shah, Rishabh Kothari, and Gautam Makadia. They are well known, they are senior enough, they don't need any introduction. So Ashish, back to you.
Thank you, sir. I think we have a very impressive panel. And I think after this initial background, we'll go further for personalized management of ALK positive non-small cell lung cancer patient. This is the case-based panel discussion. I hope my slides are visible, right?
Yes, sir.
Okay. So this is my disclaimer. So the discussion would be in the patient selection in the first line and the treatment sequencing based on the existing clinical data. So this is the patient characteristic, 43-year female, non-smoker with a very good performance, PS0. The patient having a history of nodal swelling on the right side of the neck, which she noticed by herself by chance. And she also having some other symptoms like transient headache, mild visual disturbance, reduced appetite and weight, some nausea and vomiting. And she had one comorbid illness, that is mild depression. It started at the age of 38 years, and otherwise there's no major history. With this complaint, she woke up and oncology setup where the patient has been diagnosed a metastatic non-small cell lung cancer patient. The patient stage is T4 and 3 and 1B. Patient has multiple brain metastasis. The PET scan MRI shows other than brain, they have in the lung lesions, right side neck swelling, the hilar lesions, and bilateral nodular lung lesion. The patient biopsy and molecular profile has been reported as metastatic adenocarcinoma. The patient having the ALK positive in the molecular profile, EML4 ALK gene fusion variant 1. And this is the radiological picture. You can see the patient having the multi-brain metastasis, and the other side there is a PET scan showing the nodal metastasis, lung lesion. So the patient is still having the very good performance status as if for mild CNS symptom. So let me ask for our panelists. So we have 4 panelists on board. So Dr. Akash, in such kind of the ALK positive non-small cell patient, good performance status, how do you manage and what are the factors you consider before going further for the treatment? Akash?
Yes, sir. So that age and performance status makes sense, sir. And so if there is younger age and with a good performance status and no comorbidities, so the third generation TKI will be the better option. So treatment of choice to start with the lorlatinib
Okay,
if
so
patient is asymptomatic for the brain metastasis.
patient having a mild transient headache and visual disturbance. So this is the mild symptom, but still the patient performance is really good.
Yes,
So you
so yes, transient headache, I'll start with the systemic treatment only.
okay. So Dr. Kaushal Patel, your comment, especially what are the factors you consider? Yeah.
Yeah, this is a ALK positive metastatic lung malignancy. Having some sort of the psychiatric or neurological involvements, some sort of the psychiatric components there, and the patient is having a brain metastasis. So in this
Right.
particular subset, no doubt we should go with the third generation TKI, that is a lorlatinib. But in
Mm-hmm.
considerations of these neurological psychiatric issues that sometimes exaggerated with the lorlatinib's neuropsychiatric as a side effects.
Right.
In that particular case, we can also go with the brigatinib or alectinib, but still would like to go with the lorlatinib.
Okay. Dr. Rushabh, this patient, as far as we look at the history, beside the CNS symptom, the patient having this type of depression, which is diagnosed 4 or 5 years back, the patient on the therapy. So do you consider this is a significant point in making your decision, particularly for ALK inhibitors?
So,
Yes.
as everyone told, something which will work well in CNS is important. So,
Mm-hmm.
brigatinib and lorlatinib are the options, and based on psychiatric issue, maybe this is a subset where you may think of brigatinib, but most of the time we end up doing lorlatinib if it is well controlled and patient is not symptomatic for the same the
Right.
psychological complaints.
Okay. Dr. Gautam, neurocognitive side effects. What is your take on that, and particularly with the third generation LTKI? Do you consider this one of the significantly reported in your practice, and do you consider this would be one of the major factor, particularly choosing your first line of therapy in metastatic non-small cell lung cancer is possible?
Right. Sir, I would slightly like to differ in this case. I would first choose brigatinib in this particular patient for two
Mm-hmm.
reasons.
Right.
Despite of the slightly better efficacy of lorlatinib over alectinib and brigatinib, still I would like to choose brigatinib for two reasons. One is potential neuropsychiatric complications of lorlatinib, and secondly, the sequencing which I would like to give sequential benefit I would like to give to this patient. Because
Right.
if I have failed, that patient has failed on lorlatinib, let's say after a few months or maybe years, then I would be very relatively helpless in this kind of patient, because ALK positive young patient needs a proper sequencing, in my opinion.
So very important point, and this is a young patient. This is 43-year female. Patient underlying having the state of depression, patient having the CNS lesion. So we have to be very careful choosing your first line of therapy, because if suppose the lorlatinib, which is, though it is very effective data as per the CNS, but if the patient having a neurocognitive symptom, it is going to compromise their major quality of life. So let me discuss with brigatinib data, and I think in ELTA we have the data of brigatinib. So brigatinib exploratory analysis in ELTA-1 shows a very significant overall response rate in ALK positive, particularly the various variant 1 and 3 and TP53 mutation. So historically, we know the variant 3 and TP53 mutations give the very aggressive biology of ALK positive non-small cell lung cancer patient. So in this particular study, they have been done analysis of variant 1, variant 3, and TP53 mutation patient. You can see the variant 1 is 44 in brigatinib arm and 47 for brigatinib arm. Variant 3 is little higher in brigatinib, is 40 versus 33. And TP53 mutation is 39 versus 36. You can see on the right side the response rate of brigatinib compared to the crizotinib, and the response rate is much higher compared to the crizotinib, especially in the variant 3 and the TP53, where we don't expect such impressive response with other TKI. So brigatinib shows a response in 77% of the TP53 patients, while in crizotinib is 61. Variant is 83 versus 67. Similarly, the PFS of brigatinib versus crizotinib in various variant and TP53 mutation status. So in variant 1, it is the PFS is 29 months, variant 3 it is 16 months, while with the crizotinib is 13 versus 7.4. And in TP53 mutation, it is 18 versus 7.4. So quite effective data of brigatinib compared to the crizotinib, and both the V3 and TP3 mutation, its prognostic marker poor behaves. So the intracranial efficacy is, so the brigatinib demonstrated the 4-year efficacy in patients without brain metastasis. That is 44.1 versus 21.2 months. And the median, the HR is 0.44, 56% reduction in the risk. The response rate for the patient having the baseline brain metastasis is 24 versus 5.5, and the CR rate is 45 versus 2. So very significant data of brigatinib versus crizotinib. So Dr. Akash, so what do you consider what are the strongest differentiation factor in the brigatinib data out of these 4? Either the primary endpoint, the crossover efficacy, or the patient that will taken some chemo that doesn't include. So what would be the major criteria, and how do you see this data, particularly with the CNS data of brigatinib?
So means it's compared to crizotinib, where there is no question about the second generation, except ceritinib, which is excellent CNS response rate. So it is there. There is no question that when there is we concern about the intracranial part, then either alectinib, brigatinib, or lorlatinib should be used, preferably lorlatinib. But we know all the patients will have some side effects. But here with alectinib and brigatinib, there is less side effects. There is a second generation. So crossover is permitted, means it's a we have that confusion that already Gautam has said that means either only lorlatinib is the option or sequence will make a good option. But lorlatinib has showed excellent PFS, which we have never thought that at 5 years also it's a 60% PFS is there. So I don't think that with the benefit of this much PFS, that sequence will be beneficial. Otherwise, we all might have patients which were started on the crizotinib, and right now patients are taking ceritinib or lorlatinib or alectinib, and they are surviving since 7-8 years. So some patients are actually benefiting with the sequence, but with the available data of the lorlatinib, I think sequence might be evaded. And patient who had taken some chemo were enrolled, means it will not change the OS if patient has received chemotherapy. And it was in initially trial, it was said that if patient has responded, that continue 4 to 6 cycles, and you can then switch to the anti-ALK TKI.
Yeah, but I think the study parameter is really important, because in this particular study, they've been allowed the patient to receive chemotherapy. So it's a practical situation. Many times what happens, we start the systemic therapy and we get the molecular profile later on. And then if the patient has been reported as ALK mutation or ALK has been positive, I think we either intervene and we start with the ALK TKI. So this study is taking a very real world situation where the patient having included in the ALK positive. Dr. Rushabh, So out of these factors, what are the strongest differentiation in the Olympics data, as per your opinion?
So, sir, I will just comment. Primary endpoint and crossover permitted are good to have because that gives you the bias of sequencing is removed because crossover is permitted. CNS efficacy for ALK positive malignancy is very important. So that is also a good thing which will make us to use this drug. And as you told that this is a practical situation where you give one cycle of chemo and then you get ALK report. So
Mhm.
it is a pragmatic design that these patients are involved. Uh, but as what Dr. Akash told that even after all this point, will it be it is something which is game changing. It is still difficult that CNS efficacy. We know that three drugs have good CNS efficacy, and probably brigatinib is one of them.
Mhm.
And so pragmatic design definitely helps us to take more patients, but it is nothing is like the strongest standout that no other drug has.
Okay, so as far as your opinion, the CNS efficacy and the PFS is very strongest with the lorlatinib, so that would be the major factor you consider. Right.
Yes, yes. In practical situation, when we choose the drug, uh,
Mhm.
though these all good points are there with brigatinib, we have a better drug to select when we choose first line.
Right. Yeah, well taken. Dr. Kaushal Patel, so though the OS data is not mature, the CNS efficacy of brigatinib is also is very effective, and there is no head-to-head comparison. So these are the very real-world issues where the patient having crossover is permitted and the patient having chemotherapy is allowed. So how you look this data and what the factor you consider is the strongest differentiation in the brigatinib?
Yeah, so as Dr. Rishabh told, the patient who has taken some chemotherapy were allowed. So we are routinely finding such type of the things in our practice. We are sending the patient sample for the NGS and we start with the chemotherapy. And later on, we get the reports of ALK positive and we switch over to the ALK TKI. So this is the good thing, which we have some data that even though in absence of the data, we definitely change the medications in form of the ALK inhibitors. No doubt, the primary endpoint and CNS efficacy, they are good enough. But still, in today's era with Crown 5 years data, that's a very strongest positive points. No doubt, the brigatinib is one of the good drug to use in a first line setting. But still, many doctors have their choice in form of the lorlatinib. So I will consider brigatinib because of many factors like primary points, primary endpoints, CNS efficacy, as well as the patient who has taken some of the chemotherapy in their practice.
I think we have to very carefully selection in the right patient and especially in the choosing the inhibitors. Dr. Gautam, your take on about this particular slide?
Yes, sir. Definitely, PFS advantages are there with lorlatinib as compared to brigatinib, and crossover and other things are definitely making us difficult to choose between brigatinib and lorlatinib. But CNS efficacy wise, I feel it is equally efficacious. It is no major difference between brigatinib and lorlatinib, in my opinion. So yes, it is very difficult. It is only the minor differences. But in this
Well,
particular patient, and considering the neuropsychiatric manifestation, and probably I'm somewhat more inclined regarding ALK positive disease biology about sequencing, despite of
right.
so much convincing data about PFS, but still I would choose sequencing in this young patient, even if she was not a neuropsychiatric patient.
Right. So currently we don't know the ideal sequencing. Do you offer the best in the first line, or as for I presented the case where the patient giving brigatinib and the later on lorlatinib patient getting within 7.5 years, we don't know the real answer. But to give the most potent drug and to get a lot of toxicity, that is also one of the major issues. So I think patient selection and other factors is very important. Um, if you see the various phase 3 study design for ALK inhibition, I think Dr. Akash and Dr. Usha was very particular with the the low latent data. But you can see this particular study, Alta 1, they have been not only consider the prior chemotherapy patient, but they have been taken very practical point. They have been consider the blind independent review committee assess PFS, which is not there in the alectinib, and the patient having allowed crossover. So the crossover data is basically where the patient crizotinib is given brigatinib later on. I think the comparison is compromised over data. So there are some data where we can avoid the crossover, and I think we'll come to the next slide. But this is a very, very practical situation where, as Dr. Kaushal mentioned, we start the chemotherapy and based on the result, we subsequently intervene. And of course, the patient profile is helpful in the choosing decision. So this is a very, very practical situation where the patient has been given chemotherapy and the patient has been assessed thoroughly based on the review committee and all the parameters been considered. And if you see the PFS and the OS data, I think it is quite similar, where the investigator assisted, it is 25.7 versus 24 for alectinib, brigatinib, investigator assisted 34.831 rate. So HR value is 0.43 and 0.43 in the both arm, alectinib and brigatinib. And the overall survival data is not mature as of now for all these three studies. The alectinib it is 0.67, lorlatinib it is 0.72. So the HR for brigatinib is 0.81, but the adjusted for crossover it is 0.50. So still the data is not mature for this is for adjustment crossover, because the other study they don't allow crossover. And the median duration of response for alectinib is 17.3 months, where the brigatinib is 27.9 months, lorlatinib is not potential. So very important thing. And the third one is the response at the first line. So what we are initially discussing, the lorlatinib is a very potent drug for CNS efficacy. But in this particular side, you can see those patients having the baseline metastasis. The HR for the CNS metastasis at the beginning, it is 0.21 for lorlatinib based on the crown. For ALX, it is 0.37, but in Delta 1, it is 0.25. So there's a difference of 0.21 is 0.25. That's the only difference. And so this is very small difference, and it is also very potent drug for the CNS efficacy. So Dr. Akash, how do you look at this data? So based on this data, do you consider this is for initial line or maybe for first line also or subsequent line?
Yes, sir. So whenever this intracranial part, which is always with when there is a ALK fusion is there. So these three drugs are the choice. So one of them we have to choose when there is if patient is elderly and patient doesn't want toxicity at all, then my choice will be second generation, either alectinib or brigatinib. But if patient understands that the longest PFS, both systemic and intracranial, with possible grade 1 toxicity that somehow we manage with the dose escalation or de-escalation, then I start with the lorlatinib. So otherwise, I am convinced with the intracranial for all three drugs.
Okay. So Dr. Rushabh, so now you have options for patient treated for third generation TKI in the first line setting, and also with the data of brigatinib, which is very impressive. So do you consider this in the first line or for subsequent line, or do you believe in the sequencing, and particularly for younger patient having the brain metastasis?
Sir, so when given a choice, I would start third generation first line in all the patients, but practically we know that it is not possible in most of our patients, and we end up sequencing the things. So,
Right.
so whenever we are seeing variants, and if they are good variants, so it is variant one, probably sequencing is still good enough. But if we have bad variants, I would prefer to give lorlatinib upfront.
Right.
So because PFS is at 5 years, your PFS is not reached. So the second best molecule has somewhere around 30 months. So this would be more than 60 months at least PFS. So Efficacy wise, you don't have any doubt. Rather, we should learn to manage toxicity of lorlatinib given the efficacy of lorlatinib. In some patients, like if someone is having really bad cardiometabolic reports, very difficult to manage lipid profile. In that very rare situations, we would probably not give lorlatinib. Someone having genuinely significant neuropsychiatric symptoms. So in this very few patients, we would definitely consider brignatinib or alectinib in that situation. But in rest of the situations, if given a choice, lorlatinib would be the drug of choice.
So you mentioned the molecular profile report, and you choose the decision based on the variant and TP53 mutation. So how often you see this do this test? You just test for ALK rearrangement, or you do for this particular profile where you get all the variants and the TP53?
So, because now we have moved to NGS in most of our situation, we get the variant report also in NGS. And if it is not mentioned, we can always ask the lab. They will
Right.
come up with the report. If it is done by IHC or FISH, then it is difficult to know the variant. But now,
Right.
because most of us do NGS, we know the variant.
Right, right. So this is very important thing because a lot of small panel doesn't cover that variant, and this is a very good thing because now we have the drug based on the variant reports, and we prioritize those drugs. So it is very important to get those variant report, and also for TP53 because getting these results are definitely helpful in selection in first therapy, and now we have a more potent drug to target the worst variant, that is V3 and TP53 mutations. Both brigatinib, dorlatinib is effective, and we have to give this drug over to the other TKIs. So this is a very important study where the treatment sequencing and duration of the subsequent TKI and ALK positive non-small cell lung cancer patient treated with the brigatinib in US. And this is the retrospective cohort study utilizing the US-based patient who received the drug brigatinib, and around 400 plus patients. For this particular cohort, the patient number of patients are more than 80 adult patients. 12 or more months of pre-index observation, continuous followed by post-index until the brigatinib discontinuation, 90 or more days gap in the brigatinib therapy or switch to another TKI. And they look for the time to treatment discontinuation, adherence to the therapy. So very, very practical things which you analyze in this real world setting. What they found is that we didn't follow by 8.4 months. So they didn't find the brigatinib is the treatment adherence is 92.7% of the patient. Dose compliance score is 1.0, and time to discontinuation is 10.3 months. And this is the patient profile. And the post-brigatinib treatment pattern, they've been found the lorlatinib compared to the ceritinib, crizotinib, alectinib is one of the preferred TKI, and which is somewhere around 57% of the patients. So sequencing is work, and this particular study they have been mentioned the sequencing and adherence to the brigatinib is very excellent data. The duration of the subsequent TKI, the clinical benefit post brigatinib, they've been found this for time to treatment duration 7.2 months, and particularly the patient who received the alectinib before brigatinib, and the patient with the subsequent lorlatinib, the time to the progression is somewhere around 8 months. So treatment with the subsequent LTKI still give benefit to the patient after discontinuing brigatinib. So that actually helpful in the suggesting you get sequential benefit. So that also helpful in using this brigatinib earlier line. So Dr. Kaushal Patel, do you believe this sequencing? And I think this data is very impressive, particularly using the brigatinib and keeping the lorlatinib in subsequent line, particularly those patients where the lorlatinib is little challenging putting in the first line.
Yeah, so so as Dr. Rushabh mentioned that we all wanted to give lorlatinib in a first line, so third generation TKI as a first line therapy, but because of limited resources, we end up with the sequencing treatments. So this is not a bad idea actually. We can go with the sequencing treatments, and at the progression we can change the drug. Sometimes it will give the more PFS and more OS compared to the direct lorlatinib. So that is not bad idea, actually, we can say.
So this is the standard guidelines which we follow NCCN. Those patients who initially received the crizotinib initially, if there is a progression, the patient is local regional disease progression, we treat with the local therapy, continue with the drug. And if there is a brain metastasis, we treat with the local systemic progression, we treat with the subsequent line. And those patients, there is a no local therapy is possible with the broad. So this is the standard we follow, and this is for those patients who receive the crizotinib with the first line, and suppose if the patient having the progression, systemic progression, then what you do?
Oligosystemic progression, and if
Not oligo, it's a systemic progression. So now you want to change. So what do you do? Which agent you prefer?
in third generation TKI.
So post crizotinib, third generation TKI, straightforward, or you do some molecule profile and to look for the resistant mutations. So what do you do in your practice?
So yes, sir. So very ideally, it's not required, sir. Is if there is upfront ALK fusion positive is there, and directly we can go for either second or third generation TKI. But yes, this as per different variants, there is some different effectivities there. But the most of the second and third generation for variant 1 and 3, they respond somewhere, response rate is there of 80 to 90%. So right now I don't see, and I start second or third generation TKI.
So Dr. Gautam Makaria, those patients who initially received crizotinib, in like particularly in the first slide, you can see here, and where the patient having the systemic progression. So how do you address those patients? I do directly do the second or third generation, or you do some more testing, like a biopsy or molecular profile? What do you do?
Yes, definitely. I would definitely get biopsy in this patient to identify the resistance mutation which has developed over a period of time, preferably by the fusions, the latest comprehensive NGS, including the RNA fusions, because as you know, ALK is quite importantly picked up by the RNA fusion. So yes, after that, and as Akash Bhai has told, variant identification, I can choose a better second or third generation, whether to use lorlatinib or to go with brigatinib. Yes, I would definitely get those tests done, sir.
So this is very, very important because you in the ALK domain, there are a lot of resistant mutation is emerges, and these are the acquired mutations. So it is a good idea to do a biopsy to prove histopathologically and to get a molecular profile. And as Dr. Akash and Dr. Gautam was mentioning, look for the type of mutations, because the certain mutation cannot be addressed by the alectinib, or can be addressed by the brigatinib and lorlatinib, and based on the patient profile you can choose. So more personalized, and based on the molecular profile and the mutation, you can select the further line of therapy whenever it's feasible. Coming to the safety and quality of life issues, so we have one case which is little different. This is a 42-year female, never smoker, some respiratory symptom, and based on that, she investigated and is found to be lung lesion, mediastinal lymphadenopathy, proliferation liver metastasis, and the further scan revealed the asymptomatic multiple brain metastasis, ALK positive by ISC. Best it is referred to community hospital, no material for NGS, and there is no other abnormality in the blood. And this is the MRI in the liver lesion and the lung lesion. You can see the right side lung lesion with mild pleural effusion, brain metastasis, and the liver metastasis. So in this particular situation, the patient was initially started alectinib in October 2024 to March 2025. With alectinib, the patient within a month, patient got a partial response. There is some grade 1 toxicity, anemia, and myalgia. You can see in November month, there is a regression in the brain lesion, and the liver lesion disappear. So with the 600 milligram BD tablet, it is responded. But after 5 months of alectinib, the patient having the progression in the lung lesion. And the rebiopsy showed adenocarcinoma positive, and at this time the patient having the sufficient tissue. NGS was done, and they found a variant one, and PDL positivity more than 1%, that is 49%. And the patient was offered the lorlatinib in this particular setting, 100 milligram, and till March is going. It showed a response, but at the same time, patient having some CNS toxicity like progressive paranoia, tactile hallucinations, weight gain, and pedal. But the patient responding, the liquid biopsy after one other therapy shows on lorlatinib no external mutation. The patient responded to CNS in the thoracic and the liver. So very practical situation where the patient having a short period progression. So Dr. Kaushal Patel, do you see any role of re-challenging in this situation if the patient having any say toxicity on LTKI? So do you believe the brigatinib can be useful in this particular setting or any other setting?
So I think here we have used alectinib as a first line and lorlatinib as a second line.
Right.
So we are using brigatinib first time in these patients, and yes, we can use. We can use in two conditions. Number one, we are having side effects of the lorlatinib and patient is not able to tolerate the drugs, then we can definitely switch to the brigatinib. And number two, if the disease progression over the lorlatinib, then we can go with the brigatinib. We are having some data which shows that after progression of the lorlatinib, brigatinib has some effects. So these are the two scenarios in which I would like to go with the brigatinib also.
Okay. So, Dr. Rishabh Kothari, if there is a neurocognitive dysfunction happens with the lorlatinib, what is your preferred sequencing strategy to consider chemotherapy, any other agents, or brigatinib? What do you think?
So, sir, when there is progression,
Not progression. Progression on alectinib. Now, the patient having on lorlatinib, I'm saying neurocognitive dysfunction.
Patient is not able to tolerate lorlatinib, and we want to re-challenge with brigatinib.
Yeah, neurocognitive side effects, worsening.
Yeah. So that is something which we can consider, because if we don't give brigatinib, the only thing which we can give is chemotherapy. I would give a try to brigatinib before starting off with chemotherapy.
Okay, so we'll consider brigatinib as the preferred agent. And this is for the toxicity of lorlatinib. But what about those patients who initially receive alectinib, particularly like this particular patient, and to choose the second line therapy post alectinib? We have a very effective data, and we have a bright star data, even the post marketing data of efficacy of brigatinib over alectinib. So you consider post alectinib progression, lorlatinib versus brigatinib. How do you choose? Even your mutation is showing sensitive to both the drugs.
So by default, sir, I would consider higher generation of TKI, lorlatinib. But for whatever reason, if lorlatinib is not feasible because of comorbidities or logistic reason, then I would consider brigatinib. But my choice would be lorlatinib first.
Okay. So Dr. Akash, all patients on progression of the first and second generation lorlatinib, or there is a space for brigatinib in this particular scenario?
So if lorlatinib we are not able to give due to any side effect profile, then brigatinib.
Okay. So any of the concern of the lorlatinib and brigatinib should be considered, and it is very, very effective drug in terms of all the mutations are concerned. So this is a very important slide because this will definitely helpful in choosing our agents. So this is the summary of the different LTK safety profile, and they have been compared with the crizotinib. So the first one would be lorlatinib, where the common treatment-related adverse event is dyslipidemia, edema, weight gain, neuropathy, and cognitive effects. Alectinib, there was some concern of anemia, increased bilirubin, myalgia, arthralgia, back pain, insomnia. And while brigatinib having hypertension, cough, backache, increased lipase, and increased blood creatine phosphorus. So based on this safety profile, so Dr. Akash, which is helpful in choosing your agents, do you consider this safety data as a significant in your clinical practice?
Yes, sir. But to start with the alectinib or brigatinib, the initial part is not the issue, like
Mhm.
that something we see and we just it makes any side effect profile will make us the contraindicated for the treatment, because we are not worried about the mild anemia or some myalgia or arthralgia or some increase in the
Yeah.
blood creatinine, which is there for most of the TKIs. There, if after 1 year, 2 years, that creatine will rise from zero point 0.8 to 1.4, or some hypertension. It's very common thing for all the TKIs. But
So,
as we have used lorlatinib, means almost all patients are means problem of hypertriglyceridemia and hypercholesterolemia. So we are worried about the lorlatinib toxicity, as everybody is saying first. Choose is lorlatinib, but we are always having anxiety to start with the lorlatinib counseling, and we want easy drug like alectinib and brigatinib.
the very important point, as you mentioned, Akash, because lorlatinib is potent, but at the same time, it is a concern for elderly patients, cardiac patients, neurocognitive issues, obesity. So this is very important, choosing the drug based on the safety data. And there is a one study data of brigatinib, the study based on early onset pulmonary event safety data has been there, where the patient having given brigatinib for 2 weeks and the patient looked for the pulmonary events, and they have been captured and we have analyzed in the patient. They have taken around 98 patient data, and these are the patient is 50% female patients. The patient either receive a chemotherapy or brigatinib, and what they have been found, early onset pulmonary event in 10 patient experience 11 out of that uh, 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 for first 14 days of brigatinib therapy. So 10 patient out of a total 11 pulmonary events has been reported, and what they found is three of these patients are the serious adverse events. They require pneumonia for the require hospitalization, dyspnea for requiring a prolonged hospitalization, and disease progression. But none of the serious events considered related to treatment. So unlike ELTA-3 one, this in this study, the pulmonary adverse events is basically reviewed by independent review committee, and none of this been adjudicated as a confirmed early onset pulmonary adverse event. So most of the patients they have been tolerated, and if there is any toxicity related to the brigatinib, particularly for interstitial lung disease and pneumonitis, there is standard recommendation. We have to withhold the drug and resume with the drug if there is a grade 1 toxicity, and if there is a grade 2, we have to reduce with the lower level dose. So this is standard guideline, but if there is grade 3, 4 toxicity, we have to permanent discontinue. And this is the standard recommendation for the dose modifications. If the patient had been within 7 days of starting the 90 milligram of brigatinib, if there is some toxicity, we have to reduce to 60 milligram. And the second reduction is the permanent discontinue. If the patient on 180 milligram, then the reduction would be first reduction would be 120 milligram, and then 90 the modifications based on the tolerance. So Dr. Gautam Makaria, now this drug is available as 30 milligram, 90 milligram, 180 milligram. So do you believe this it gives quite flexibility as far as the dose modification is?
Yeah, definitely, sir. With this, yes, there is a lag-in period, and this lag-in period is definitely useful, sir.
Okay. I think we have been given a very impressive outcome for all the panelists, and one of the important thing is with the availability of the all the first and second third generation TKI, we have to be very selective for choosing the drug. Not only with the efficacy and the safety data is very important. So those patients having underlying comorbidness, we have to choose the drug which is causing the least toxicity. And I think most of the panelists in the same page, giving the most potent drug at the beginning and with the considering the safety data. So now we have a lorlatinib, brigatinib, alectinib, all the drugs. So with the different patient profile, we need to choose the drugs. With this, I thanks to all the panelists, and over to you, sir, for your final and expert comment. Thanks.
Thank you, Ashish. I don't think I have any comments on the molecule or the disease because you have covered each and every point. So I will just, end and conclude by thanking you for giving a wonderful lecture, followed by an excellent moderation. And I must thank Akash, Gautam, Kaushik, and Rishabh for being such an excellent panelist. I think we've understood the finer points of how to select and adjust the dose, and we can therefore optimize the management of our patients with ALK positive non-small cell lung cancer. Thank you very much.